Good day, everyone. Welcome to today's lecture on assessment and anxiety disorder. And we are now guided by the latest updates from the DSM 5 TR. Let me explain to you what this DSM means. It's the Diagnostic Statistical Manual, and that this is used by psychologists to diagnose mental disorders. And if you notice in the Introduction to Psychology by Plotnik, Plotnik still uses DSM-4 TR. And I would like to inform you that there is now a latest version of the DSM, which is the DSM-5 TR. And the TR means text revision. Okay, there have been updates on diagnostic criteria and in categorizations of disorders. So if you know, mental health is a growing concern globally. And here in the Philippines, we're seeing increasing awareness of conditions like anxiety, depression, and trauma-related disorders. Whether you're preparing for clinical practice or research or community outreach, understanding how we assess and diagnose these conditions is essential. In this session, we'll explore what defines a mental disorder according to DSM-5 TR, the multifactorial causes of mental illnesses, including biological, psychological, and environmental factors. Also, we are going to talk about how abnormal behavior is conceptualized across different frameworks, and also the DSM-5 TR's updated diagnostic structures. And finally, a deep dive into the anxiety disorder chapters, including generalized anxiety disorder, panic disorder, social anxiety disorders, specific phobia, agoraphobia, and related conditions. Okay, so this lecture is not just about memorizing criteria, it's about learning to see the person behind the symptoms, understanding their story, and applying evidence-based tools to support recovery. Let's begin by defining what we mean by mental disorder in clinical term. According to the DSM-5 TR, a mental disorder is a syndrome characterized by clinically significant disturbance in cognition, emotion regulation, or behavior that reflects dysfunction in underlying psychological, biological, or developmental processes. This definition is foundational. It guides how clinicians assess, diagnose, and treat mental illness conditions or mental health conditions. But to truly understand it, we need to break it down into three core components. Number one component is called significant distress. This refers to marked psychological sufferings that goes beyond what's considered a normal reaction to life's challenges. For example, imagine a senior high school student who experiences intense anxiety before exams. While some nervousness is expected, this specific student has sleepless nights, nausea, and even experiencing panic attacks, clearly beyond typical stress response. So, this level of distress may indicate an anxiety disorder. Number two that we're going to look into is the functional impairment. Here, the disorder interferes with important areas of life. For instance, the work, school, maybe relationship, or maybe daily routine. Example, is a sari store owner who develops depression may lose motivation to open the store, neglect inventory, and withdraw from customers. This affects both livelihood and social functioning. And the third that we're going to consider is the cultural context. DSM-5 TR emphasizes that the disturbance must not be solely culturally sanctioned response to specific events. For example, in some indigenous Filipino communities, communicating with ancestral spirits is a respected tradition. In some reports, hearing voices in this context, it may not be considered pathological. Okay, it may not be considered a psychological problem. However, if the voices are distressing, command driven, and impair functioning, further assessment is warranted. By the way, when we talk about impaired functioning, that means it already disrupts the normal functioning of a person. Okay? And why do you think this definition matters? This operational definition helps clinicians avoid over pathologizing normal behavior while ensuring that those truly in need receive important care, appropriate care. It also encourages cultural sensitivity, which is especially important in diverse societies like ours. As we move forward, keep in mind that mental disorders are not just diagnostic labels. They represent real struggles that require empathy, evidence based assessment, and culturally informed care. Now, what are the contributing factors in mental disorders? Okay. Understanding this is what we call the etiology. Understanding the etiology of mental disorders is essential for accurate assessment and effective treatment planning. So, the DSM 5 TR emphasizes that mental disorders arise from complex interactions among biological, psychological, and environmental domains. Let's explore each of these details. Number one is biological factors. Biological factors refer to physiological and genetic influence that predispose individuals to mental illness. It's like there is no escape because it is genetically contributed. Okay? So, genetic contribution studies estimate that heritability for many disorders ranging from 30 to 60%. For instance, a family with a history of depression or maybe schizophrenia increases risk or the absence of environmental even the absence of environmental triggers. Okay, so brain abnormalities, for instance, structural or functional changes such as the hyperactive amygdala or linked to anxiety disorders. um, in the Philippine context, the neuroimaging is limited in rural areas, but clinical signs like exaggerated fear responses may suggest underlying brain dysfunctions. And the next is called neurotransmitter dysregulation. Basically, this is the imbalance in serotonin, dopamine, and norepinephrine that affect mood, anxiety, and cognition. For example, a person with low serotonin level must possibly elicit depressive symptoms or maybe obsessive compulsive symptoms. Okay? Then the next one is called the neuroendocrine alteration. This is basically regulation in the HPA axis, so maybe do a little research about it. It can lead to chronic stress response. Example, OFWs experiencing prolonged separation and work stress may show elevated cortisol levels, contributing to anxiety or burnout. Number two, cognitive, emotional, behavioral factors. These involve internal psychological processes that shape how individuals perceive and respond to stress. Okay? Maladaptive schemas, deep-seated beliefs like I'm worthless or I must be perfect. These thoughts can fuel anxiety and maybe depression. Example, a student who usually internalizes failure may develop chronic worry and avoidance behavior. Okay, the next thing is emotion regulation deficits. What is it? This is difficulty managing intense emotions that can lead to impulsivity or withdrawal. Okay, for instance, cultural norms may discourage emotional expressions, especially among men, leading to suppressed distress. Okay, this is very common here in the Philippines. Inadequate coping strategies. Okay, reliance on avoidance or maybe substance use or denial can worsen symptoms. Okay, for instance, a young adult in turn turn to alcohol to cope with job loss or making underlying anxiety, right? Okay. Next is called learned maladaptive behavior. This is actually repeated exposure to dysfunctional family dynamics that may normalize unhealthy responses. Example, maybe a children is raised in a household with frequent conflict may develop hypervigilance or aggression. Okay. Next thing, environmental factor. These are external influences that shape mental health outcomes. Trauma and chronic stress, exposure to violence, disasters, or prolonged hardship can trigger disorders. For example, those survivors in the recent earthquake and the typhoon Tino, may develop post-traumatic stress disorder, especially if displaced or bereaved. Okay. Another thing is called adverse childhood experience, the ACEs. Abuse, neglect, and household dysfunctions are linked to long-term mental health risks. Example, a child growing up in poverty with absent caregivers may struggle with attachment and emotional regulation. All right. And then another thing, social support deficits, isolation or strained relationships increase vulnerability. In the Philippine context, there are a lot of Filipinos who work overseas, and overseas migration often separates families, leaving children with their limited emotional support, right? Another factor, socioeconomic stressors, employment, housing insecurity, and systematic inequality contribute also to psychological distress. Okay? For instance, informal settlers in urban areas may experience chronic anxiety due to unstable living conditions. All right? But the thing is that there is an integrative perspective among these areas because no single factor causes mental illness. Instead, it's the interaction among these domains: biological predisposition, psychological vulnerability, and environmental stress that determines risk and resilience. Maybe you guys, as future clinicians or educators, or maybe mental health advocates, we must assess these layers holistically. Okay? Because in the Philippine setting, these means considering not just symptoms but also cultural beliefs, family dynamics, and systematic or systemic changes that shape mental health. Now, before we dive deeper into diagnosis, let's explore how clinicians and researchers have historically defined abnormal behavior. Because understanding these frameworks help us appreciate the evolution of mental health assessment and why DSM-5-TR adopts a particular approach. Number one is statistical frequency. What does this mean? This approach defines abnormality as behavior that deviates significantly from statistical norms within a population. For example, if only 1% of the population hears voices, this behavior is statistically rare. Do you agree with me? Right? However, take note, rarity alone does not mean pathology. It does not mean a certain problem. Because the limitation is that not all rare behaviors are disorders. For instance, genius level IQ is statistically infrequent but not pathological. Okay? Or maybe a child prodigy excelling in math at age 6 may be rare, but this doesn't warrant clinical concern. Okay? Are you still following? The number two is called deviation from social norms. Here, behavior is considered abnormal when it violates cultural or societal expectations. For example, let me give you an example. Walking barefoot in a mall may be seen as socially inappropriate. In contrast, in rural areas, this might be normal, right? Okay. Now, the limitation of this is that social norms are culturally relative and change over time. What's considered abnormal in one barangay may be acceptable in another. For instance, spiritual possession may be pathologized in urban clinics but respected in indigenous healing rituals. Okay. Number three, maladaptive behavior. This is the approach adopted by DSM-5 TR. Behavior is considered abnormal when it causes significant distress or functional impairment. What does this mean? Example, a college student avoids all social interaction due to fear of judgment may be experiencing social anxiety disorder. So the behavior interferes with education and perhaps also relationships and also emotional well being. The advantage of this approach is that this approach is clinically useful. It focuses on the impact of behavior on the individual's life, regardless of how common or socially acceptable the behavior may be. All right? Now, let's move on to clinical assessments in DSM-5 TR framework. Accurate diagnosis and effective treatment planning begin with a comprehensive clinical assessment. Take note of that. Effective treatment before a psychologist can create an effective treatment planning, there should be a comprehensive clinical assessment that should be done first. The DSM-5 TR emphasizes that assessment must gather information across multiple domains to identify symptoms patterns, evaluate severity and duration, and assess functional impairment. Let's walk through the five key components of this framework. Number one component is called clinical interview. This is the foundation of assessment. Interview may be structured. When we say structured, it's using standardized questions. These are questionnaires that assess if a client experiences symptoms that fall under a specific disorder, or maybe a form of a checklist. Number two is called semi-structured interview. This is guided but flexible. The psychologist may ask questions from a form, but free to ask probing questions if necessary. Okay, and also there are type of unstructured interviews. These are open-ended and conversational. This is a free-flowing questions or free-flowing interview followed by probing questions. Okay, so for example, in usually in barangay health centers, semi-structured interviews are often used due to time constraint and limited resources. So maybe clinicians or psychologists or mental health professionals would ask, "Kumusta man ang imong tulog karong simanaha?" Or kumusta imong tulog karong adlaw gabi yun ana. And that question is to explore if there's any sleep disturbances. Okay? Are you still following? Number two, psychological testing. This is the step two. Standardized tools help quantify symptoms and personality traits. So, one of the examples is the MMPI, and also another one is called the Beck Depression Inventory. MMPI means the Minnesota Multiphasic Personality Inventory 3. It helps identify conditions such as depression, anxiety disorders, substance use disorders, and personality disorders. On the other hand, also Beck Depression Inventory are a family of psychological assessment tools. There are actually different versions, and these are designed to measure symptoms of depression, anxiety, hopelessness, and other emotional states. They are widely used in clinical practice to aid diagnosis, monitor treatment progress, and guide intervention planning. Okay. And the other technique also is sometimes it's the projective technique, the use of Rorschach and TAT. Okay, the thematic perception test. So perhaps you make a research about this. This is a psychological assessment method where individuals respond to ambiguous stimuli like ink blots or pictures. I think you really had to make a research about this. The purpose is the idea is that people project their unconscious thoughts, feelings, and conflicts onto the stimulus. And what's the use? They are used selectively, often to explore personality dynamics, defense mechanisms, or unconscious processes, not as primarily diagnostic tool. Okay, so in the Philippines, while MMPI-3 is available in some hospitals, many clinicians rely on locally validated tools like the Filipino version of the Beck inventories, especially in academic settings. Now, number three, behavioral observation. This involves watching the client's behavior, affect, and interpersonal styles. When we talk about affect, this refers to emotion and also the way they deal with other people. Can occur in clinical settings or maybe natural environments. Okay, and this also helps identify nonverbal cues, social withdrawal, or agitation. Okay, example, a child in a public school may be observed during recess to assess social anxiety. Does the child avoid peers, show signs of distress, or isolate? So, like that. Then, number four, it's called medical evaluation. This is the step number four. It's crucial to rule out organic causes of psychological symptoms, such as maybe example is neurological exam, or maybe lab tests, like for example, thyroid functions, vitamin deficiencies. So that's that for instance. Let me give an example. A patient presenting with fatigue and low mood may be referred for a CBC and thyroid panel at a local diagnostic clinic to rule out anemia or hypothyroidism. Okay, these physical illness could have caused the mood problem. All right. Okay, so number five, this is now the risk assessment. This step evaluates potential harm to self or others. For instance, suicidality, homicidality, and other vulnerability factors such as abuse or neglect. Okay, example, a teenager is possibly experiencing hopelessness and withdrawal, may be screened using the Columbia Suicide Severity Rating Scale, followed by safety planning and referral. This is to see if there is a risk of harming the self or others. Okay? Now, the DSM-5-TR represents a major shift in how mental disorders are conceptualized and documented. One of the most significant updates is the elimination of the multi-axial system used in DSM-4-TR. Instead of separating disorders across five axes, so if you want to clarify about this, you make a research about what are the contents of DSM-4 and then compare it with DSM-5. Now, DSM-5 TR adapts a more integrated dimensional approach. Let's break it down. Let's break down the key components of these updated frameworks. Number one is the disorder categories. The DSM-5 TR organizes disorders into 20 chapters grouped by phenomenological similarity and developmental patterns rather than theoretical causes. Example, anxiety disorders are grouped together because on shared features like excessive fear and behavioral avoidance, even though their causes may differ. Okay? So this structure helps clinicians in community settings like rural health units quickly identify related disorders without needing deep theoretical training. Okay, number two is it's called clinical specifiers. These are detailed notations that describe number one, severity, either it's mild, moderate, or severe. For example, if a person is experiencing anxiety, is it mild, moderate, or severe? And also the onset, is it are the symptoms happening early or late already of a specific event? And then course, or is it episodic or chronic? Episodic means it occur sometime in a certain trigger, but chronic is that most of the time it happens. So other relevant features, such as with panic attacks, with melancholic features, example, a diagnosis of major depressive disorder might include the specifier with peripartum onset for a mother in experiencing depression after childbirth. Just to explain to you, a peripartum onset refers to the timing of major depressive disorder, specifically when the onset of symptoms occurs during pregnancy or within 4 weeks after childbirth, according to the DSM-5. Now, number three, dimensional assessments. DSM-5-TR recognizes that symptoms often exist on a continuum, not a binary categories. What does it mean? This allows for nuanced clinical descriptions, encourages use of rating scales to assess severity and change over time. And why do you think this matters? This framework reflects a more realistic view of mental health, one that acknowledges complexity, overlap, and individual variation. It also supports culturally sensitive practice, allowing clinicians to describe symptoms without forcing them into rigid categories. In the Philippine context, where access to specialists may be limited, this approach empowers general practitioners, psychologists, and counselors to provide more accurate and personalized care. Now, let's turn our attention to one of the most clinically relevant chapters in DSM 5TR, anxiety disorders. Okay? And according to statistics, a lot of people, generally, people experience anxiety disorders. This is the most common disorder among the different types of disorders. So, anxiety disorders are the most prevalent class of mental disorders, both globally and here in the Philippines. They are characterized by excessive fear and anxiety, often accompanied by behavioral disturbances such as avoidance, restlessness, and impaired functioning. What are the core anxiety disorders? DSM-5-TR identified several primary anxiety disorders. Number one is called generalized anxiety disorder, or the GAD, generalized anxiety disorder. Persistent, excessive worry across multiple domains. For instance, finances, health, academics, and if a person, for instance, in terms of finances, thinking about finances, there will be other symptoms that may fall this specific stimuli or stimulus that would determine that this person is going through general anxiety disorder. Number two is panic disorder. This is a recurrent, unexpected panic attack with fear of future episodes or behavioral changes. We're going to later on give you the diagnostic criteria for each of these anxiety disorders. And also agoraphobia, that is now separated. Before, agoraphobia is part of panic disorder, but this is now a separate diagnosis. Agoraphobia means fear of being in situations where escape might be difficult or help unavailable. Another factor is called specific phobia, intense fear of specific objects or situations. For example, fear of heights, fear of animals, or fear of injections. Okay. Another anxiety disorder is called social anxiety disorder. This refers to fear of social or performance situations involving potential scrutiny or embarrassment. Okay. Another thing, separation anxiety disorder. This refers to excessive fear of being separated from attachment figures, often seen in children. Okay? And next is called selective mutism. This is consistent failure to speak in specific social settings despite speaking in others. Okay? Example, a child who speaks freely at home but remains silent in school for months may be exhibiting signs of selective mutism, specifically if the silence causes academic or social impairment. Now, what is the importance of reclassification of disorders? Two disorders previously grouped under anxiety have been reclassified due to distinct features. For instance, the obsessive compulsive disorder, now placed in its own chapter. Obsessive compulsive disorder and related disorders. Okay, this reflects its unique neurobiological and phenomenological profile. Also, the next one is the post-traumatic stress disorder, or also known as PTSD, now under trauma and stress-related disorders. This change acknowledges the central role of trauma exposure in its development. Example, for instance, survivor of Typhoon Tino experiencing flashbacks and hypervigilance would now be assessed under the PTSD framework, not anxiety disorder. Why these changes matter? These reclassifications reflect an updated understanding of etiology and symptoms patterns. They help clinicians make more accurate diagnosis and tailor interventions more effectively. All right. Now, let's just focus on panic disorder. Okay, let's talk about panic disorder first. This is a condition marked by sudden, intense episodes of fear known as panic attacks. According to DSM-5-TR, panic disorder is characterized by recurrent, unexpected panic attacks followed by persistent worry about future attacks or significant behavior changes aimed at avoiding them. Importantly, DSM-5-TR maintains panic disorder and agoraphobia as separate diagnoses, recognizing that panic attacks can occur independently of avoidance behavior. Now, what is the diagnostic criteria? To meet the criteria for panic disorder, the individual must experience recurrent, unexpected panic attacks and at least 1 month of persistent concern or worry about additional attacks, maladaptive changes in behavior, for example, avoiding places or situations. Now, what are the panic attack features? Greater or equal 4 are required for a person to be diagnosed with panic attack disorder. A panic attack is a sudden surge of intense fear or discomfort peaking within minutes. DSM-5-TR lists 13 symptoms and at least 4 must be present. Number 1, palpitation or accelerated heart rate. Number 2, sweating, trembling, or shaking. Number 3, shortness of breath or smothering sensations. Number 4, chest pain or discomfort. 5, nausea or abdominal distress. 6, dizziness, lightheadedness, or feeling faint. And also the realization or depersonalization, fear of losing control or going crazy, and fear of dying. Okay, let me give you an example. Maybe a call center agent may experience sudden chest tightness, rapid heartbeat, and fear of collapse during a night shift. Afterward, they begin avoiding work altogether, fearing another episode. This pattern may indicate panic disorder. And the evidence based treatment for panic disorder is the known cognitive behavioral therapy, and this is considered the most effective long term treatment. This includes interoceptive exposure, that means that gradual exposure to feared bodily sensations, for example, racing heart. Okay? Also, cognitive restructuring, that means challenging catastrophic thoughts. For example, such as thought nga, let's say, I am dying. Okay? So example, a student learns through CBT that their dizziness during exam is not life-threatening, reducing avoidance and panic frequency. Number 2 also, second treatment could be considered is the SSRI, or the serotonin reuptake intake. I forgot that term. The first line treatment example, these are the medication, sertraline and paroxetine. Okay. Also the SNRI. Just make a research about this. Alternative options: the benzodiazepines used for acute relief, but with caution due to dependence risk. Okay. Now, let's explore general anxiety disorders, or the GAD, a condition marked by persistent excessive worry that is difficult to control and affects multiple areas of life. According to DSM-5-TR, GAD involves excessive anxiety and worry occurring more days than not for at least 6 months across domains such as health, finances, academics, or relationships. The worry is not limited to one specific issue and is often accompanied by physiological arousal symptoms. What are the core features? To meet the criteria for GAD, the individual must experience excessive worry across multiple life domains. There are different domains of life, difficulty controlling the worry, and symptoms present more days than not for more than or equal to 6 months. Okay, take note of that. Clinically significant distress or functional impairment. Okay, for example, a mother constantly worries about her children's safety, finances, and health, even when there's no immediate threat. She finds it hard to sleep, feels tensed, and struggles to focus at work. This pattern may indicate general anxiety disorder. Associated symptoms: greater than 3 or equal 3 or more required. For children, only 1 is required. Restlessness or feeling keyed up, easy fatigability, difficulty concentrating, irritability, muscle tension, sleep disturbance. Okay? Let me give you another example for this. A senior high school student who reports feeling parang laging may kaba. May inanab ito, pirmi siya kulbaan. and struggles to concentrate during exams and has trouble sleeping due to constant worry about grades and maybe family expectations. Okay? Now, in terms of treatment approaches, maybe a psychotherapy, which is again, let's go back to cognitive behavioral therapy, which as I discussed a while ago, this could be a good this is a good treatment approach. Okay, it targets worry patterns, intolerance of uncertainty, and also the cognitive distortions, those thoughts that are catastrophizing. So, for instance, a client learns to challenge thoughts like, if I don't check my phone every hour, something bad will happen, and replaces them with more balanced thinking. And also, the second is the SSRI and the SNRIs. These are medications. Okay? Now, third is the adjunctive interventions. Maybe using relaxation technique, mindfulness based interventions. These help reduce physiological arousal and improve emotional regulations. All right. Now, let's examine social anxiety disorder, previously known as social phobia in DSM-4-TR. This condition involves a marked and persistent fear of social or performance situations where the individual may be scrutinized or negatively evaluated. The fear response is disproportionate to the actual threat and often leads to avoidance, behaviors that interfere with daily functioning. What are the diagnostic features? To meet the DSM-5-TR criteria, the following must be present: marked fear or anxiety about one or more social situations involving positive or possible scrutiny, fear of negative evaluation, being judged, embarrassed, or rejected. Social situations almost always provoke fear or anxiety. Situations are avoided or endured with intense distress. Symptoms persist for at least 6 months. Causes clinically significant distress or impairment. Okay? So for this instance, I'll give you an example. A college student avoids oral presentation or maybe group discussions or even casual conversation with classmates due to intense fear of being judged. Okay? Despite being academically capable, the student's performance suffers. This may indicate social anxiety disorder. And the evidence-based intervention for this is again the CBT, the cognitive behavioral therapy. Okay? So through gradual exposure to feared social situation or maybe cognitive structuring to challenge distorted beliefs, like for instance, if I do something, everyone will laugh at me. Okay? So that can be changed using the CBT approach, often delivered in individual or group format. Okay. All right. Now, for social skill training, as part of the intervention that used when skills deficits contribute to anxiety, it includes behavioral rehearsal, role playing, and feedback. Okay. And again, pharmacotherapy, the SSRIs and the SNRIs. We've been talking about this since ganina, so maybe do more research about this. Um, the beta blockers, these are medications. Okay. Now, let us examine specific phobia, a type of anxiety disorders characterized by marked, persistent, and excessive fear triggered by a specific object or situation. The fear response is immediate and intense, often leading to active avoidance or enduring the situation with significant distress. The DSM-5-TR categorizes specific phobias into 5 distinct types, each with unique features and typical pattern of onset. Okay? So types of specific phobias. Number 1, animal type. Those fear of animals or insects like fear of dogs, fear of snakes, spiders. Okay? And typically begins in childhood. All right? Example, a child refuses to enter a room if a gecko or in Bisaya patiki is present and crying and trembling despite reassurance. Okay, this may reflect an animal type phobia. Okay, number 2, natural environment type. Okay, that's fear of natural phenomena such as maybe example storms, heights, waters, and this often begins in childhood again with variable persistence. Example: a resident avoids going near the shoreline after surviving a typhoon, experiencing panic symptoms when hearing strong winds. Okay. Number three is the blood injection injury type. Fear of blood, needles, or medical procedures, unique for its vasovagal response, may cause fainting. Okay? For instance, someone faints during routine vaccination drives. Okay, maybe the COVID-19 um, vaccination. Okay, maybe somebody fainted because of it, not due to pain but intense fear of needles. This pattern suggests a blood injury or blood injection injury phobia. Number four is the situational type. This refers to the fear of specific situation. For example, flying, elevators, or enclosed spaces, and often develop in early adulthood. For instance, maybe someone avoids riding elevators in high-rise buildings or choosing stairs even when it causes physical strain. Diba? Now, number five, other types. Phobias that don't fit the above categories is, for instance, fear of choking, vomiting, loud sounds, costume characters, diba? These are um, other types of phobias, and these do not belong to a certain category. Okay? Now, the key diagnostic requirement to distinguish clinical phobia from transient fears, DSM-5-TR requires that the fear of anxiety must be persistent, typically lasting um, equal or more than 6 months. It must cause clinically significant distress or impairment. Okay? Let us now turn to agoraphobia. Okay, a disorder that involves marked fear of or anxiety about situations where escape might be difficult or help may not be available in the event of panic-like or incapacitating symptoms. A key update in DSM-5-TR is that agoraphobia is now recognized as a distinct, standalone diagnosis, no longer tied to panic disorder as a specifier. This change reflects growing evidence that agoraphobia can occur independently of panic attack. What are the diagnostic criteria? So, to meet DSM-5-TR criteria, the individual must experience fear or anxiety about two or more of the following situations, lasting at least 6 months: using public transportation, being in open spaces such as parking lots or marketplaces, being in enclosed space, for instance, shops or maybe theaters, standing in line or being in crowd, being outside the home alone. Okay, let me give you a scenario. A vendor in maybe Carbon Market in Cebu begins avoiding crowded jeepneys and busy stalls due to overwhelming fear of something bad happening. Okay, marang inana. Over time, she refuses to leave her home alone, relying on family members for errands. These patterns may, this pattern may indicate agoraphobia. Now, the clinical presentation. The core fear centers on difficulty escaping or obtaining help if symptoms arise. This leads to active avoidance of feared situation, severe restriction of daily activities, in some cases, homebound behavior. Okay? So, for instance, maybe a retired teacher avoids malls, church, gatherings, and even walking outside alone, fearing she might collapse and no one would assist her. Okay? Then treatment, what one of the most effective treatment is called exposure therapy. Now the bad thing is here is that you'll be exposed to the thing that causes you anxiety or fear. Okay? Consider the gold standard treatment in terms of this problem. Involves gradual, systematic exposure to feared situations. Then helps reduce avoidance and build confidence. Okay, let me give an example. A client starts by walking to the gate alone, then progresses to short errands, eventually riding public transportation and support. Okay, and another help could also be pharmacotherapy, the use of medications. Okay, Now, let's examine also the obsessive compulsive disorder, the OCD. This is also common. Sometimes we call someone OC, okay, but I think we're not really referring to OCD because OCD is already a problem. A condition that has been reclassified in DSM 5 TR, it is no longer grouped under anxiety disorders but placed in its own chapter. It now belongs to the obsessive compulsive and related disorders, or the OCRDS. This change reflects updated understanding of OCD's distinct phenomenology, neurobiology, and treatment response patterns, which differ significantly from other anxiety disorders. There, this reclassification significance involves OCD involves intrusive thoughts and repetitive behavior, but its underlying mechanisms, such as rigid cognitive patterns and compulsive rituals, warrant a separate diagnostic category. So, this classification helps clinicians tailor treatment more precisely and avoid mislabeling OCD as generalized anxiety disorder. What are the core features of OCD? Number one, obsession. Okay? Obsession, these are recurrent, persistent, and intrusive thoughts, urges, or images that are experienced as unwanted and cause marked anxiety or distress. Okay? So common themes include contamination, for example, fear of germs or dirt. Okay? So if a person is afraid of germs, this person might, for example, nakagunit siya og coin or something that this person think that there is germs in this, in your hand, and this person will wash the hand over and over, and that is the compulsion part. Okay. Now we're talking about the obsession first. The obsession, for example, another is fear of causing injury to others. Okay, another also is the need for things to be just right, the symmetry. Okay, kanang if you see that the pencils are not well arranged, you have the tendency to arrange the pencils. That is an example. Okay, another example: a student may constantly worries that they might accidentally offend religious icons and spends hours mentally undoing the thought. This may reflect religious themed obsession, which are common in highly devout cultures. Now, the second one, the compulsion. These are the repetitive behavior. Now, take note, guys, when we talk about obsession, these are the recurrent, persistent, intrusive thoughts. But when we talk about compulsion, these are related to the repetitive behavior, okay? Or maybe mental acts performed in response to obsession or accordingly to rigid rules. Okay, the goal is to prevent or reduce anxiety even though the behavior is not realistically connected to the feared outcomes. Example include excessive hand washing. Katong naay nagthink nga nahugaw yung kamot. After maybe every after a minute or 5 minutes, magsigisag wash ang hand. Okay, checking locks repeatedly. Okay, so this happened to me a lot. Sometimes I go back home to check if I lock the door. Okay, so counting or praying in specific patterns. Okay, and then mental rituals such as neutralizing bad thoughts. Okay, a homemaker checks the stove 20 times before leaving the house, fearing a fire despite knowing it's off. This compulsion is driven by intrusive harm-related obsession. Okay, so now this time, let's explore two diagnostic categories that underwent significant reconceptualization in DSM-5 TR: the post-traumatic stress disorder and the somatic symptoms and related disorders. These changes reflect evolving understanding of trauma-related responses and medically unexplained symptoms. The PTSD, the post-traumatic stress disorder, this M5TR now classified PTSD under a new chapter, traumatic and stressor-related disorders, emphasizing the central role of trauma exposure in its development. What are the core features of PTSD? PTSD develops after exposure to actual or threatened death, serious injury, or sexual violence, either directly as a witness or through repeated exposure to trauma-related details. Okay, what are the symptoms clusters? To meet diagnostic criteria, symptoms must persist for more than 1 month and include intrusion symptoms. These are flashbacks, nightmares, intrusive memories. Okay, it's like they are reliving the experience. Another thing is avoidance, efforts to avoid trauma related thoughts, feelings, or reminders. Also, negative alterations of in cognition and mood, those guilt, shame, detachment, distorted beliefs, etc. Alterations in arousal and reactivity, those who are hypervigilant, irritable, exaggerated startle response. Okay? Kanang dali ra makuratan. Okay. So, for instance, maybe if we may use the Typhoon Tino as an example, maybe there are people who experience nightmares, and maybe some of them avoid rivers and coastal areas and become easily startled during storms. Okay, so these symptoms may indicate PTSD, especially if they persist and impair functioning. Okay, the somatic. Let's talk about the somatic symptoms and related disorders. DSM-5-TR replaces the outdated term somatoform disorders with a more nuanced category, somatic symptoms and related disorders. This shift reflects a move away from focusing solely on medically unexplained symptoms. So terminology changes. Somatic symptom disorder replaces somatization disorder. What is SSD, the somatic symptom disorder? This involves one or more distressing physical symptoms such as pain, fatigue, gastrointestinal issues that are disproportionately associated with excessive thoughts, feelings, or behaviors related to those symptoms. The symptoms may or may not have medical explanation. Okay? The focus is on the psychological response to the symptoms, not whether they are medically explained. Common behaviors include frequent doctor visits, health related anxiety, and preoccupation with bodily sensations. Example, a client might repeatedly seek medical attention for headache and stomach pain despite normal test results and expresses intense worry about having a serious illness. Okay? Another is called illness anxiety disorder, and this replaces hypochondriasis. IAD is characterized by preoccupation with having or acquiring a serious illness despite minimal or no somatic symptoms. Individuals may frequently check their body, seek reassurance, or avoid medical care altogether. The anxiety persists for at least 6 months and causes significant distress or impairment. For instance, for example, a young adult constantly fears they have cancer despite normal screenings and spends hours researching symptoms online. Okay? Sometimes that's what we do. We educate ourselves with our symptoms and then uh, we self-diagnose, di ba? Something like that. Another disorder is called the conversion disorder. Is now called functional neurological symptoms disorder. FNSD, it's called FNSD, involves neurological symptoms such as paralysis, seizure, blindness that are incompatible with medical findings and not explained by another condition. Symptoms are real and involuntary, not faked, often linked to psychological stress or trauma. Okay? Now, factitious disorder. Factitious disorder remains the same in DSM-5 TR but is better defined. This disorder involves intentional falsification, intentional, take note. For factitious disorder, this disorder involves intentional falsification or induction of physical or psychological symptoms without obvious external incentives, for example, money or legal pain. The motivation is to assume the sick role and gain attention or sympathy. Okay, this can be composed. This can be imposed on oneself or maybe imposed on another. Example: a caregiver including illness in a child. A caregiver inducing illness in a child. Like for example, a caregiver repeatedly brings a child to clinics with exaggerated symptoms despite no medical findings, possibly reflecting factitious disorder imposed on another. Okay, what are the key conceptual shifts? DSM-5-TR emphasizes positive symptoms such as excessive thoughts, feelings, and behaviors related to health concerns rather than the absence of medical explanation. All right, so that will be all for today. If you have any questions, please send me a message through my Google chat box. God bless everybody. Bye.